It's my honor to be here and to talk to you today about managing some of the side effects that come along with cancer treatment. Thank you for that introduction. As you mentioned, I'm a medical oncologist. I treat breast cancer. And so, we're going to talk about a lot of the practical things that we encounter and go through a range of different options of how we can address this. So to start off with, I'm just going to talk about what is menopause. We hear this word out there a lot, but what does it actually mean? So one of the definitions is that menopause is defined as the period that happens 12 months after the last menstrual period. And then that is sometimes termed menopause, and it's associated with a myriad of different physical and mental changes. The term post-menopause or post-menopausal is basically the rest of a person's life after this, menopause time point. And then perimenopause, another term we hear a lot, is considered the transitional period prior to menopause, where hormone levels can fluctuate significantly. People may experience physical and emotional changes, and on average, this can typically start in someone's 40s, but that can be a very wide range, and it can last for months or even years. So these are some of the standard definitions that are out there about these terms. But let's hold on, not so fast, because this doesn't really account for what everybody is experiencing and going through. Because periods can stop, but that doesn't always mean menopause. So what am I talking about? If somebody had, for example, a hysterectomy, their uterus was removed, but their ovaries were left in place, well, they're not going to have menstrual cycles anymore. However, their ovaries are still going to be producing hormones. What if somebody had a uterine ablation? Again, the bleeding may stop, but the hormone production doesn't stop. What if someone has an IUD? Again, the periods may stop, but they're still not in menopause necessarily because of that. And then, certainly, when people go through a period of illness, surgery, many other things, there can be a change in periods, or even periods can stop without it actually being menopause. And then what about the impact of cancer treatment? There's many things that come along with breast cancer treatment that can impact hormone levels, having periods, menstrual bleeding, or menopause. So let's talk about that. So number one, what about chemotherapy? If a person is premenopausal and receives chemotherapy, that can impact ovarian function. Endocrine therapy, and I'm going to kind of go through this a little bit more in a few slides, but that can either serve as hormone blocking treatment or hormone lowering treatment as part of breast cancer management. And then some people undergo removal of the ovaries as a component of a cancer treatment, and that can cause a surgical menopause if someone's premenopausal and then has their ovaries removed. So let's talk about chemotherapy. So if somebody is premenopausal and goes through chemo, they have a risk of developing menopause as a result of that, and that varies widely. So it depends on the age of their person, their underlying, hormonal state, what type of chemotherapy they got, the dose, the duration, all these different factors. So there can be a really wide range of the likelihood of menopause after chemotherapy. And another thing to mention, if somebody gets chemotherapy, periods can stop for a while, but then they can resume. So ovarian function can still resume even if someone hasn't had a period for over a year after chemotherapy. Endocrine therapy is a way to work on the hormonal pathway. So tamoxifen is a pill. It's a selective estrogen receptor modulator, a SERM. And many people ask me, will this put me into menopause? Does this cause menopause? And tamoxifen, if a premenopausal person takes tamoxifen, it does not induce menopause. However, periods can stop and there can be symptoms that are menopausal symptoms. So tamoxifen is an effective treatment for both pre and postmenopausal women with breast cancer, and the side effects are menopausal symptoms. Aromatase inhibitors, on the other hand, work in a different mechanism. They block the conversion of a kind of precursor hormone into estrogen, and they are only effective if a person is postmenopausal or premenopausal and has a method to suppress the ovarian function. So that brings me to ovarian function suppression. This is something that can be given as an injection to temporarily stop the ovarian function. So this I would consider a temporary medical menopause that lasts while the effect of the medicine is in someone's system. And then when the medicine is stopped, if the ovaries are still able to produce hormones, naturally they will be able to. And if someone has gone through menopause in that time period, then they may not be producing hormones after that from the ovaries. And sometimes people have removal of the ovaries. So why would this be recommended, or why would this be done? So for some people, they may be found to have a genetic mutation that predisposes to ovarian cancer. And so ovaries can be removed as a way to reduce the risk of an ovarian cancer to develop. For other people, this might be a method of stopping ovarian function as part of the endocrine therapy plan. And then there might be a reason that's not related to a breast cancer diagnosis or a cancer risk reduction option. So there could be a different gynecological reason. And then in addition to removal of the ovaries, sometimes one of the options is actually removal of the fallopian tubes only without the ovaries. And this is done at times because it can still reduce the risk of what we call ovarian cancer, even removal of the tubes, because some ovarian cancers can initiate in that tissue without removing the ovaries and without causing a surgical menopause at that time. So this sort of lays the groundwork for different scenarios of hormonal changes, how this relates to cancer treatment, and what we're really talking about when we're talking about menopause and menopausal symptoms. So now talking about what are these effects. So menopausal symptoms, there's a wide range. These are not all of the symptoms that people might experience, but some of the common ones are going to be hot flashes, night sweats, muscle aches or pains, joint aches or pains. Sometimes people describe brain fog or this foggy thinking, neurocognitive changes, mood changes, sleep changes, and then sexual health. So today I'm going to focus on just a few of these symptoms and talk about sort of strategies to manage this. So I'm going to talk about hot flashes and joint aches, and then later we'll go into detail about sexual health also. So hot flashes and night sweats, these are common symptoms that can occur as a result of medicines that are used to treat breast cancer. So we see these in women taking tamoxifen, an aromatase inhibitor, and basically these are one of the common side effects. So when I'm talking about managing side effects, the first thing that we always think about are what are lifestyle modifications or behavioral modifications that might be able to help. And so sometimes people will relate that hot flashes have certain triggers. And so if there is a correlation, and sometimes those are foods, for example, caffeine or spicy foods or different things like that, avoiding or recognizing triggers for hot flashes. Exercise is an important component of healthy lifestyle overall, and is key to managing many of these side effects. And then there is a treatment called acupuncture, and this has been studied for people with breast cancer who are having hot flashes, and there's mixed results, different trials. Some show it helped, some show it didn't help, but this is one of the things that can be tried to manage hot flashes without medication. And another thing that actually has shown benefit is something called cognitive behavioral therapy, and this is sometimes delivered in group settings and has been shown to reduce the impact of hot flashes on how somebody feels. So now let's go into medication options. So these are what are called non-hormonal medications to manage some of these menopausal symptoms that people may be getting. So one of the options falls under a category of antidepressants, but they can actually be used not for their antidepressant properties, but to reduce the hot flashes. And so there's a range of different antidepressants that can be prescribed, depending if somebody is taking tamoxifen or if somebody is taking an aromatase inhibitor. There are some interactions between certain medications and tamoxifen, so that has to be selected carefully. And then for some people, these medicines, they are antidepressants, so they also can help with mood symptoms and sometimes help with joint symptoms too. And they can have different side effects as well. And for certain antidepressants, some of those side effects include sexual dysfunction. The next medicine I'm going to talk about is called oxybutynin. So this is a medicine that was originally used as a medicine for bladder leakage. So someone who had urinary incontinence might be prescribed this medication. But now we know that it may also have benefits in reducing hot flashes. And we can use this even at a low dose, which would be 2.5 milligrams twice a day. And it can reduce the symptoms of hot flashes and sweating. Because of the type of medicine it is, it can cause side effects like dry mouth, dry eye, and because it was treating leaky bladder, if someone didn't have leaky bladder, they could have difficulty starting their urination. So we always kind of balance what is somebody experiencing and then what medications can we use to manage this. This is one that can also be used if somebody's having both leaky bladder symptoms and hot flashes. It could be a useful option. There are some risks of long-term cognitive impairment especially in patients who are considered elderly. And so I do kind of use that cautiously in patients who are older. The next treatment for hot flashes is gabapentin. So gabapentin is actually a neuropathic pain medicine. So it helps for a neuropathy type of pain is the original use of that medication, but it can also reduce hot flashes and night sweats. And one of the side effects of this medicine is drowsiness. And sometimes that can be actually used to advantage if people are waking up at night, having trouble sleeping, having night sweats that are waking them up. Sometimes this medicine can both reduce the hot flashes and night sweats and help with sleep a little bit at night. So sometimes we sort of look at what is the pattern? Are these more during the day? Are they more at night? How is the sleep? And try to see which of these medicines makes the most sense. Another medicine that is sometimes used for managing hot flashes is called clonidine. And this is actually a blood pressure medicine. And in some studies has shown to reduce hot flash incidence, but can have impact, of course, on blood pressure and for some dry mouth, constipation, other side effects like that. And then now we have some newer medications that can treat hot flashes. And these are really interesting because these are primarily intended to treat hot flashes. So elinzanetant was the first medication in this class that was FDA approved 2 years ago. And this was actually approved not specifically for people who had breast cancer, but who were experiencing menopausal vasomotor symptoms. And the studies that led to the approval did not include people who had breast cancer. And in terms of side effects, it's known that there's a low chance of impact to the liver. And so monitoring liver enzymes is part of this follow-up. While people with breast cancer were not included in in the studies that led to this approval, it is sometimes discussed and mentioned as an option for people who have breast cancer who are experiencing hot flashes. And there is a phase 3 trial in patients with breast cancer that is currently ongoing. And then there's another medication that works in a similar way called elinzanetant. And this is not currently FDA approved in the US, but they have specifically investigated this medicine in people with breast cancer. And it was found to reduce the number of hot flashes per day over placebo. And so, we'll be watching this very closely to see if this is approved and if this becomes an option specifically for people with breast cancer. But it's really encouraging to see new research, new mechanisms to combat hot flashes. The next side effect or symptom that I'm going to talk about is musculoskeletal symptoms. And this is a really big one because a lot of people experience muscle pain, joint pain, stiffness that can be extremely disruptive to their lives. And the incidence varies, but this is something we know we see this very commonly, probably more so on aromatase inhibitors than tamoxifen, but it can certainly happen with both. And this is one of the reasons that sometimes people stop taking the medication. And so being able to manage it and improve it is important to help people stay on their medicines. So as always, lifestyle interventions are key. And specifically for musculoskeletal symptoms, exercise is really important. And exercise, they have looked at this, it can reduce pain. And among the people who exercised more, there was more pain reduction compared to those who exercised, but not as much. So this is really one of the just first initial treatments for the joint aches and pains. And acupuncture, again, has also been studied for this and may reduce pain caused by aromatase inhibitors and medicines like that. And also yoga has been studied too as a specific form of exercise, and this can also help with the musculoskeletal symptoms. And then just practically speaking, many doctors will employ what's called a switch therapy. So if somebody is on one aromatase inhibitor, like letrozole, for example, they may say, okay, let's switch to a different aromatase inhibitor like anastrozole and exemestane. And, just in my own experience, making a switch sometimes can have a dramatic change on how somebody feels with one of these side effects. Some people also employ what's called a brief break or a washout period. And so that's always an individual discussion with somebody's oncologist, but a break or a washout sometimes helps to diminish the symptoms so that someone actually can exercise and then start on a new one as a way to kind of smooth out those side effects. In terms of medications, non-steroidal anti-inflammatories are effective in reducing pain, but of course, using a medicine like that long-term on a regular basis is limited because of other side effects that can develop. And then duloxetine is a medication that's also in an antidepressant category, but it has been shown to improve joint pain, stiffness, that interference that pain is having on people's lives and their functionality. There is an interaction with tamoxifen, so if somebody is on tamoxifen, this might not be the choice for them. And then there's supplements. So some of these supplements have been studied in randomized trials, and one of them is actually called tart cherry, which showed an improvement in pain symptoms. So this is one of the options that we can discuss in terms of a non-prescription or a supplement medication. There were other supplements that have been looked at with research as well, including vitamin D, E, omega acids that may not have been found to be effective. And the glucosamine, interestingly, there is a little bit of data on that in terms of what's called a single arm trial, meaning everybody took the same thing, which did show some reduction. But we always like to see, a group not taking it and a group taking it to understand if this is beneficial. In my own experience, some of my patients really do find that glucosamine is helpful to their joint pain. So why don't we pause here and just see if there's any questions before moving on to the next section?
That would be great. I was just going to say there are definitely questions. But first, will you be addressing hormone replacement therapy in the next section, or should I ask those questions now?
I have a slide at the very end about hormone replacement therapy, so we can ask those at the end.
Okay, great. So one question is around drug interactions. So do you have, what are the names of either an SSRI or an SNRI that does not interact with an AI?
So most of them will not interact with the aromatase inhibitor. So it's really more the tamoxifen that, we have to be really picky about which of the medications that we look at in terms of the drug interactions. So, with any new prescription, obviously you have to, talk with your doctor about what medicines you're on and if there are any drug interactions. But the interactions that I've mentioned, I'm really more concerned about them with tamoxifen.
Okay, great. And I know you were using the chemical names, but Veozah was the drug you were referring to, right? That's been approved.
Yes, elinzanetant is the one that is FDA approved in the US, but did not include participants with breast cancer in their trial.
In their first, right? But they're doing a trial now, and there's another one. I don't know if it has a brand name yet that might be approved, right?
Mm-hmm. Okay. Right. So the elinzanetant is not FDA approved. It's not approved in the US, but that is the trial that has specifically looked at individuals with breast cancer.
Right. So we should keep our eye out for that.
Mm-hmm.
Someone's asking that she's heard some negative aspects of taking gabapentin, in that there was something controversial. Do you have any information on that?
Well, I think each of these medicines, I'm just briefly going over them, but if somebody is considering that, any of these medicines, certainly they will bring it up with their medical teams and go through all the different side effects in general. So gabapentin in particular, can have different side effects. I think I mentioned sedation or sleepiness is one of them. For some people, it's swelling or weight gain, and then there's going to be other, a list of other potential side effects as well. And so, that's one of the reasons that um, sometimes that medication is more helpful at a bedtime dose, whereas other times people will take it throughout the day. These are all sort of tools in the toolbox and trying to find which medication might be most beneficial to which person. And some of that may also depend on how an individual responds to that medicine. Does it help with their symptom, and do they have any side effects on it as well?
Okay, great. There's a lot of questions about sort of, do menopausal symptoms ever get better? So with
Mhm.
natural menopause, I think there is the sense that over time they may get better. That's not always true. But if you are taking an AI and or maybe ovarian suppressed, do you find that symptoms do taper over time?
So the most important thing is everybody is going to have their own experience with it, and there's not really a universal pattern that people will go through. But I will say, in my experience treating many, many patients with all these different forms of endocrine therapy, sometimes the side effects are more severe in the beginning and then can lessen with time as well. And I think some of that might have to do with people incorporating more lifestyle interventions or, the different dietary modifications that are helpful, exercise. But also, I think the side effects can on their own lessen a little bit. Now, everybody is going to be different in terms of their own experience and the time course and the severity and things like that. But I do think it's a common pattern where the side effects are more intense in the beginning, and then maybe several months or 6 months in, I'll have people come in and we'll be going through the note. Oh, last time you were telling me about the hot flashes and the joint aches, and they'll say, they don't really bother me that much anymore.
Mhm.
So sort of this lessening over time is something that we frequently see.
Okay, and then for people that are ovarian suppressed with Lupron or another drug, is the question is that more, is that experience different than someone who is going through natural menopause?
Well, certainly when ovarian suppression is initiated, typically it's because somebody is premenopausal.
Yeah,
And the action of it is to abruptly stop the ovarian function. And so rather than natural menopause, which can, have hormonal changes over a period of years, this is basically, one week to the next. It's an abrupt menopause at a younger age. And so for many, those symptoms are more intense and more sudden because of the way that that medicine works and the time point in somebody's life when it's initiated.
yeah. Okay, and the last question, and then we'll get to your second half, which is sexual health, and that will help us address some of the other pending questions. But is it better to take tart cherry supplements or actually drink the cherry juice?
So, the actual study that looked at tart cherry, I believe, used a syrup. So it wasn't really the juice, it was more of a concentrate. And that's harder to find. I mean, I think most of my patients that use that will find like a supplement pill in general is more readily available.
Okay. All right. Well, thank you. Well, I'm going to let you do your second half of the presentation. So keep putting your questions in the Q&A.
So now we're going to move into the next section, which is all about sexual health. And so this is really a very common set of side effects and symptoms that people can experience through breast cancer treatment and beyond. And what I'm going to talk about is that some of these things are what I would consider to be menopausal effects, which are attributable to changes in hormones. But then there are also so many other things that might come along with breast cancer diagnosis and treatment that can also impact sexual health. And so whenever I talk about sexual health, I put this out in a context of what's called a biopsychosocial framework. That means biological, physical things, mental, emotional things, and social, interpersonal things. They all come together and experience and influence someone's experience with sexuality, and cancer treatment can disrupt all of those different areas. So when we're talking about sexual health, some of this is called the genitourinary syndrome of menopause. So that means because of lowering of hormones like estrogen, there are impacts to the pelvic genital urinary health, and that includes vulvar, vaginal dryness, thinning, less blood flow, less lubrication, narrowing of the vagina, shortening of the vagina, lessening of the elasticity, pelvic floor dysfunction, that has to do with the muscles that support the pelvic organs, and they need to work together to relax at the right time and to be strong enough. And when that balance is off, it can cause a variety of different things, including pain with intercourse. Sexual response is arousal, desire, orgasm. That can be changed by hormonal changes and other things. Body image changes occur, relationships are impacted. So we're really talking about many different aspects of sexual health. So the genitourinary syndrome of menopause, we kind of mentioned some of these, the dryness, decreased lubrication, it can contribute to pain or discomfort with sexual activity. Sometimes even bleeding. If there's any bleeding, that needs to be evaluated. That's an important symptom. There can be lowering of arousal. And then really it's important to understand that these changes are actually really important to someone's health, regardless of whether they are sexually active or ever wish to be sexually active in the future, because people can have irritation, burning, itching of the vulva, vagina. This can even impact what clothes people wear, what activities they do, discomfort with, sitting, wiping, all these just everyday activities, burning or discomfort with urination, frequency and urgency. So all of these are encompassed in what's called, it's now termed the genitourinary syndrome of menopause. And these can all be things people experience after breast cancer treatment with hormonal effects. And so for the symptom of dryness, vaginal and vulvar dryness, one of the first steps in treatment involves using moisturizers. So it's key to understand that moisturizers are for the health of the tissue. They're meant to be used on a regular basis, regardless of sexual activity. So I hear that really often. We might talk about this, and then somebody uses a moisturizer prior to intercourse, and it doesn't help that much. But really, it's because they're intended to be used on a regular basis. So typically, this will be 3 to 5 times per week. Every day is fine. And now there's many products that contain hyaluronic acid in it, which can pull in and keep in more moisture to the tissue. Lubricants, on the other hand, are intended to reduce pain and discomfort from friction. And so there are some products that are both work as a moisturizer and a lubricant, but in general, I have people kind of think of these separately. And there's lubricants that are water-based. You have to be really careful with which products you choose, because many of them don't have the right pH or the right concentrations. And certainly we want to be very careful about what is added to that product, because there's a lot of things out there. They say they're tingling, warming, flavored, but really what might happen is they might burn and actually make matters worse. There's another type of lubricant called a silicone-based lubricant, and that is, for many people, longer lasting. They do caution it may stain, and they do caution to be cautious using it with a silicone covered toy or something else like that. But in general, moisturizers on a regular basis for the health of the tissue, lubricants, either a well-selected water-based or a silicone-based lubricant. And here are some brand names of products. Natural oil moisturizers, they can help the symptom of dryness. And you saw on the list, genitourinary syndrome of menopause has many more things besides dryness. But if someone's experiencing mild dryness, these can be helpful. And then many times now, I just jump straight to those hyaluronic acid containing products because they probably have the greatest moisturizing benefit. And then vaginal hormones. So really the cause of these symptoms is the lowering of the estrogen and the impact that it has on that tissue. And so in general, a low dose vaginal estrogen or vaginal hormone is the treatment for genitourinary syndrome of menopause. But of course, for people who have especially a hormone receptor positive breast cancer who are being treated with endocrine therapy, we need to understand, what are we doing when we're treating with a vaginal hormone, even a low dose vaginal hormone. So here I've listed just a few different products that are available, prescription products that are available um, to treat genitourinary syndrome of menopause. So now I'm going to go through in a little bit of detail, what do we know and how do we approach the use of low dose vaginal hormones in somebody who has a hormone positive breast cancer. So many medical societies have put on guidelines that address this. So ASCO, which is the big medical oncology or oncology organization, says women who have hormone positive breast cancer and conservative measures are not working can use a low dose vaginal estrogen. Sorry, my slides keep skipping ahead here. Um, after considering discussion of risks and benefits. And that's pretty much what these other organizations, the ACOG, which is the Gynecology Society, as well as the Menopause Society and International Society for Women's Study of Sexual Health. Basically, if non-hormonal methods are not effective, discuss risks and benefits, and you can utilize these products through what's called shared decision making. So shared decision making basically means that we explain what is known about this, what is not known, how does that fit into somebody's specific situation, and how do they feel about that information. Oh, and one more. American Urological Association also just this year, I believe, put out their guideline statement on genitourinary syndrome of menopause, and it's wonderful that they specifically addressed breast cancer and again, shared decision making. So some of the data we have about vaginal estrogen use and breast cancer comes from a study called the Danish cohort study. So this was published in 2022, and it looked at what had happened in the past, people who had breast cancer, who received vaginal estrogen, who didn't, and what were their recurrences overall. And so looking at the whole group of people, with breast cancer, there was no difference in recurrence or mortality among those who used vaginal estrogen and those who didn't. However, in the subgroup that used aromatase inhibitors, they did see a higher risk of recurrence, but not of mortality, which is survival. And this study, in many ways, doesn't really align with the way things are done today because, number one, people with lower risk cancers didn't receive any endocrine therapy in that time period, which was, which was decades ago. Number two, this preceded HER2 testing. So they weren't testing for it, they weren't treating for HER2 positive breast cancer, and that could influence the outcomes or the recurrences. So it's good to know this information, but in my opinion, it doesn't 100% apply to the way things are done today. So after that, a couple additional trials were published. So this one here looked at a group of nearly 40 or over 40,000 patients who were diagnosed with breast cancer and then were diagnosed with genitourinary syndrome of menopause. About 5% of them were treated with vaginal estrogen. And here's where there's some information missing. They didn't have the information on everybody about whether it was hormone receptor positive or hormone receptor negative. But they did know for about 10,000 people that they had hormone receptor positive breast cancer. And out of those, about nearly 4% had vaginal estrogen. And overall, the risk of breast cancer recurrence was comparable between those who had vaginal estrogen and those who didn't in the overall population. So that was reassuring. And that also held true among those who had estrogen receptor positive breast cancer. So that is reassuring as well. However, the question about what about aromatase inhibitors and vaginal estrogen at the same time, in my opinion, this study was extremely limited in being able to pick out the people who were taking them at the same time. They did report a higher risk of recurrence in that group, but the numbers were so small that it's not, really valid to make a broad generalization. And then a third study, this one looked at survival or mortality. And the reason is in Scotland and Wales, they have databases where they can say, okay, here are all the people who had breast cancer. These are the ones who were prescribed vaginal estrogen. And then this is whether or not they are surviving at a certain time point. And here we see that vaginal estrogen users did not have a higher risk of passing away of breast cancer. That means there was no higher risk of mortality with vaginal estrogen. And when you look at these numbers, actually this is lower. It was a lower risk of mortality. And then they picked out estrogen receptor positive breast cancer, no difference. And then they picked out the people who were on aromatase inhibitor. And again, this is actually a lower risk. This doesn't mean that vaginal estrogen lowers the risk, but what it does mean is this is very reassuring that we can look at this and say using a low dose vaginal estrogen does not hurt anybody's life expectancy. This particular study didn't look at recurrence. Everyone wants to know about recurrence, not only survival, but this study only reported out on survival. And then earlier this year, there was yet more information added to this using a database called the SEER cohort or the SEER database, and it looked at women who were 65 years and older. And they found over 18,000 patients with breast cancer, looked at the ones who used vaginal estrogen versus the ones who didn't. And actually, they said the ones who used vaginal estrogen, they actually had an increased overall survival, an increased breast cancer survival. And the longer they used it, the better the survival was. So this study actually did not say anything about were they taking aromatase inhibitors and vaginal estrogen at the same time. But again, it adds to what we do know. This was presented as an abstract, so hopefully we'll get more information if they report out a full paper in the future with this data. So the concern that people might have about vaginal estrogen is it going to be absorbed into the bloodstream? And if so, what is that going to do for cancer recurrence risk? So there's different studies that have looked at this. This is just one graph from a study that looked at what is called ultra low doses or 4 microgram doses of vaginal estrogen in the orange, and then show after it was given how many hours after the administration, what did the hormones do. So these higher doses that are not commonly used anymore did have spikes in estrogen, but the lower doses, 10 and 4, had very small doses on the first day and then even smaller by day 14. This information here is taken from a study on people who did not have breast cancer, who are not on aromatase inhibitors, but it's showing, especially with these, what I would call ultra low doses, that systemic absorption seems to be very low.
Can I ask, can you go back to that slide?
Sure.
I've never seen that, and I'm just curious, but so even with the lower doses, is the efficacy the same? Is it still as beneficial?
It's still beneficial, yeah. Mm-hmm.
So
It may not be
without,
the same, but it's a FDA available dosing, not specifically for people who have breast cancer, but this is a, prescription dose, the 4 micrograms,
yes.
and it's an effective dose.
Okay, sorry. Thank you.
Yeah, this is a available and effective dose. What about other hormones? So there's another hormone that is called DHEA, and this is a prescription product that's available. It's called prasterone. And there was actually a trial looking at postmenopausal women with breast or gynecological cancers, and they could be taking tamoxifen or aromatase inhibitors. And they were given this vaginal DHEA versus a plain moisturizer as the control. And they found that estrogen level, estradiol, was increased in people who use this DHEA. However, this is a precursor hormone that gets converted into estradiol. So the people who are on aromatase inhibitors, the enzyme that blocks that step, they did not have an increase in estradiol. So this is it's a different hormone that is on the list of options that we can discuss through a shared decision-making context. So this is vaginal DHEA or vaginal prasterone. So now I'm going to move past the vaginal estrogen question into these other symptoms. So some people may not be experiencing the dryness, or they may have had it and it was treated with moisturizers and or low-dose vaginal products, but are still experiencing pain with penetration, with vaginal penetration. And this could be something called pelvic floor dysfunction. And sometimes, often, I will say, we actually see people have what's called an overactive pelvic floor, meaning that the muscles are hyperactive or too active and might be too tight, and that can cause pain with penetrative intercourse. And it can also cause urinary retention or urinary leakage and constipation. And then other things, pelvic pain, hip pain, back pain can also be a symptom of that. Other people have what's called an underactive pelvic floor. And that's when there could be symptoms or issues like organ prolapse or also urinary incontinence. And so for pelvic floor dysfunction, um, we really work closely with pelvic floor physical therapists. So these are specialized physical therapists on this part of the body, and they can do treatments that may involve stretching, strengthening, biofeedback, other types of treatments. And one of the things that's often recommended or utilized is something called a progressive vaginal dilator, which is a series of cylindrical kind of devices that start at a smaller length and caliber and then increase. And this is a tool that can be used to help with symptoms of pelvic floor dysfunction. And sometimes these are recommended to be used for 5 to 10 minutes per session, a couple times a week, and that can help with some of the symptoms of pelvic floor dysfunction. So typically, if I'm talking to somebody about this, we will refer to pelvic floor physical therapy and kind of work together to devise a treatment plan. I think it's really important to emphasize that if there's a pelvic floor issue, it could be one problem or it could be something different. And so I don't typically tell people to do exercises on their own without actually getting diagnosed with what is the issue and what are the right exercises to be doing here. Another big issue is what's called sexual response. So that has to do with desire to have sex, arousal, which is mental and physical, and then orgasm. And really, we actually did a study that we published, and this was actually the most common sexual concern that was reported in our study was low desire. And so when we're talking about this, one of the first steps is just understanding that I kind of say desire comes in two flavors, spontaneous and responsive. And even if somebody has a decrease in spontaneous desire, they often can still work with what's called responsive or reactive desire. And that basically means instead of desire coming first and then leading to arousal, things that increase arousal may come first, and then the desire comes as a response or as a reaction to that. Another important thing is to review the medication list. There's lots of medicines that may negatively impact desire and sexual response. And then there's other tools that have been around, some for decades, like the sensate focus is a technique that couples can do together, often with the guidance of a sex therapist, kind of working through different issues with them. Mindfulness is getting more and more attention on how important it is in sexuality. Sometimes people's thoughts will be going in all different directions and not be able to really focus on the moment. And so practicing techniques of mindfulness outside of sexuality can be helpful then to employ to help with sexual response. And then there's a particular type of a mental health professional that's called a certified sex therapist. And they have additional expertise in helping people who are confronting issues or concerns about sexuality, and they can help with individuals and they can help with couples as well. And then there's several medications that have been shown to have benefit in sexual response. And I will say all three of these would be considered off-label for individuals diagnosed with breast cancer. So the first two, flibanserin and bremelanotide, they are both FDA approved for premenopausal women who have a condition called hypoactive sexual desire disorder, which, according to that definition, the problem is not related to a medical condition or a medication. However, flibanserin, which is a pill taken at bedtime, so every night, it has been studied in people with breast cancer in a single arm study and did show improvements in sexual outcomes when people took this medication. One of the side effects is it can make people sleepy, but actually in that study, it helped people sleep better. They actually slept for 1 extra hour a night with that medication. So I think, we would love to see more data or more research come out on this with a randomized trial, but it is, one of the tools in the toolbox or one of the options that can be considered. Bremelanotide, to my knowledge, has not been studied in individuals with breast cancer, so there's really less information about that, but this is a self-injected medication, so someone would give themselves an injection, and some of the side effects on that are going to be nausea, which you don't really want to encounter that if you're trying to have sex, but that is one of the options. And then that can be managed with nausea medications as well. And then testosterone, there's a good amount of data on testosterone in general in terms of a medicine that can help with sexual desire. However, the overlap and really the understanding of how does this impact people who have been diagnosed with breast cancer, really there's not so much solid data that we can counsel people on. So those are some medical options. But I always tell my own patients that these medications are not going to really overcome the things listed in the top here, like understanding desire or working with a counselor or things like that. But sometimes, on occasion, they can be helpful tools as well. Body image is a really important issue as well. And this is one that so many aspects of breast cancer treatment can impact somebody's body, and people can experience changes in how they feel about their body as well. And this is going to be multiple things will go into how this can be addressed, but one of the important things on there is kind of understanding that this is something that if you're working with a counselor, you can bring up thoughts about body image, that this is something that's very important, and that this is something that can improve with a number of different things, including counseling. And then relationships. I mean, relationships are important when it comes to sexuality, of course, and going through cancer treatment, there's so many changes and, issues that can arise with a relationship and the partner going through perhaps their own medical issues, their own mental and emotional issues as well. And so focusing on communication and sometimes employing use of counselors or sex therapists can be very helpful too. So here I'm going to just briefly touch on systemic hormone therapy. So I talked a lot about what I call local vaginal hormones, low dose, but systemic hormone therapy is hormonal treatments that are meant to affect the whole body. And so this is typically not recommended after somebody has been diagnosed with a hormone receptor positive breast cancer. There might be variation in what people are recommended after being diagnosed with a hormone receptor negative breast cancer. But this would always be approached in the context of what we call shared decision making, understanding the risks, understanding the benefits, and how something like this would fit into an individual situation. And then I want to call out what I would consider to be a couple special circumstances. So one thing is we talked at the beginning of the presentation that sometimes people are recommended to have their ovaries removed, not as a method to treat the breast cancer, but to reduce ovarian cancer risk. For example, if someone had a triple negative breast cancer and they were found to have a BRCA mutation or other mutation that confers an increased risk of ovarian cancer. So if you think about it, if that person didn't have their ovaries removed, the ovaries would still be producing the regular premenopausal level of hormone. But if they're removed as a ovarian cancer prevention, that's a different circumstance than if it was part of the breast cancer treatment. And then, we're focusing on individuals who have been diagnosed with breast cancer, but there's another category that's called previvors, where somebody might have a genetic mutation that predisposes to a cancer risk, but has not been diagnosed with cancer themselves and may undergo treatments that could induce a premature menopause, like removal of the ovaries. And that would be a different circumstance as well.
Well, thank you. And yes, I'm going to try to get through some of these questions. Just the first one, which is kind of overarching. I mean, you are so knowledgeable, but what do you think most breast medical oncologists have this depth of knowledge? Do gynecologists, like, where do people go to get this kind of information if they're not finding it with their own medical oncologist?
Is this specific to sexual health, or is this?
Well, the whole thing, everything you're covering, which is
well, I would say in terms of managing the side effects of tamoxifen or aromatase inhibitors, that does fall under what should be the wheelhouse of a medical oncology team. And I think what I would really put out there is that I think it's really important to communicate not only what side effects you're having, but how are they impacting your life? Because that really kind of influences which path it would be best to go down for an individual. So whenever we're talking about side effects, it's first and foremost important to understand what is the amount of benefit that anybody is having from a cancer treatment, what are the other options? Like, can we switch to a different aromatase inhibitor? Can we switch to tamoxifen? And then what are the mitigation strategies, or what other things could be done to reduce the side effects? And there's, many options on the table, and for each individual person, that path might look a little different. Um, but I think it's important to share, the experience, and I hope that will help to kind of get some answers and get at least some options.
Okay, that's great. And we have a lot of resources on our website, and there's a lot in the chat. So I hope people are continuing to learn from each other. There's a lot of questions about weight gain, whether someone is on an AI or tamoxifen, really struggling. So just any thoughts you have about, and some people are saying, will this go away when I go off tamoxifen? What's been your experience?
Yeah, so that's certainly one of the big side effects. I didn't really touch on it in this talk, but weight gain certainly can happen through cancer treatment with or without the hormonal medications added on top of it. And it can be really challenging. And so, first and foremost is the importance of the lifestyle factors, the nutritional changes, and the exercise. And those will be beneficial, even if they don't result in the desired amount of weight loss, because it can be harder to lose weight, on these medications compared to how somebody's body might have responded to that level of nutrition or that level of exercise before. I think there's a lot of interest, of course, in these GLP-1 medications coming out, and, are they going to be effective? Are they safe? And this is all evolving, and there's a lot of research interest. And so hopefully in the near future, we'll get more data on how effective are they. There's some, suggestion that they may not result in as much weight loss in people who are on some of these medications, but I think we need a lot more information about it. And so certainly, I have a lot of my own patients come ask, is it okay for me to go on these medications for weight loss? And again, we share, there's just not that much available, but weight loss is a good thing. And, understanding what do we know, what do we not know, and how does that fit into someone's situation at this point in time. I think we're gonna be learning a lot more about utilizing those medications as well.
Yeah, thank you for bringing that up. And it's certainly something that I think Living Beyond Breast Cancer wants to cover more, because we're getting a lot of questions. Are these medications safe? Should I try it? And now there's microdosing, so lots to learn. There are questions. A lot of the participants really liked your slide on the different moisturizers, and of course they wanted you to flip back to it. But
Oh yeah, I'll flip back to
information
it.
is available. But if you want to flip it back, and if people want to take a picture of it, that would be great. But are there any specific products, brands that you like? Obviously, Bonafide has products. I mean, we all get stuff in our inbox and on our feed, but are there specific brands that you like?
Yeah, these ones down here at the bottom, I think
Great
are
graphic.
great. Yeah, so especially this bottom brand here has a range of products. So the ones that I recommend to my patients include the hyaluronic acid containing moisturizers. And then they also have a moisturizer without hyaluronic acid that can be helpful as well. And then I guess I didn't really talk about it very much, but these products, some of them come in creams or gels, and others come in what's called a suppository, which is like sometimes like a little egg-shaped, device that you put, or a egg-shaped suppository that you put into the vagina, and it melts with body temperature and then, releases the product. And so some people prefer the gels or creams because they can be well used on the external vulvar tissue as well, where a lot of symptoms are. Other people feel that's messy or they don't like it and they prefer the suppository. So I would say if you try one product and you don't like it, just there's a lot of stuff out there. Try another one, try a different form. This one here, the first one listed, comes in both a gel or a suppository. And then there's going to be different price points on the products too.
Yeah, I was just going to say that all of these, there are different price points. That's something to pay attention to. Sometimes, I don't know if FSA ever covers this, but I know cost has come up as a concern.
Yeah, and there are beyond these brands, I mean, there'll even be a drugstore brand might have a hyaluronic acid containing suppository.
Right. So that's what everybody wants to look for. Great.
Mhm.
So this is a question that I think is going to be hard to answer, but I'm going to ask it because I know it's common. If you were diagnosed with breast cancer just as you were entering menopause, it can be really hard to distinguish the list of issues that you suddenly start facing, whether it's high cholesterol, pre-diabetes, frozen shoulder, weight gain. And so how do you separate out like what is the menopause, just menopause, and then what is the AI that these people might be taking?
Yeah, so of course that can be really tricky because without stopping the AI, letting it fully wash out of the system and seeing what's left, there's really no other way to differentiate, what's what. And of course, there's going to be concern with taking a prolonged gap from a medication in terms of outcomes and an efficacy standpoint. But I think one important thing to understand is that I cannot emphasize enough how important lifestyle interventions are. And so, whether it's through menopause or through the side effects of medications, changes in lifestyle interventions are going to be important, regardless of which one it is. And so, the question was, how do you differentiate? So, without stopping a medication, there's really not a way to 100% know what's what. But the same things, the same lifestyle changes that are helpful for one are also helpful for the other.
Okay, thank you.
And also, if someone gets this isn't really this topic, but if someone has high cholesterol, we know it's so important to treat cardiovascular risk factors. And so, I sometimes hear people say, well, it's just a side effect. I maybe don't need to treat it. Absolutely. This is the time that those cardiovascular risk factors, such as, cholesterol, A1C, glucose metabolism, all of those, blood pressure, they all need to be optimized through a combination of lifestyle and medical interventions.
Thank you. There's a question about contraception and what moisturizers, lubricants work with condoms. They've had some problems. Do you?
So I think, for that, one would have to specifically check on the product. They should say whether they're compatible or not compatible.
Okay.
And so, if someone's using condoms for pregnancy prevention, then it's important to check the product specifically and understand what type of condom is being used and if that's compatible with the product. So, for example, oil-based products are often not compatible with condoms because they can cause breakdown potentially. So that's a
Okay.
really important point to check. What is the product you're using? Is there a condom being used, and is that compatible?
Okay, great. I'm going to just ask a few more. So you addressed this, but I don't know if you have more to add. If patients have triple negative breast cancer, and are really thrown into some hard menopausal symptoms, is hormone replacement therapy a possibility? I know you said it's a discussion, but sort of how do you approach your triple negative patients about this?
Yeah, so I think that there's not really a clear um, consensus in terms of can we tell people this is safe or no, you can't have it, right? So then there's going to be what's the middle ground in between that. And that involves a detailed discussion about what do we know in terms of people who had triple negative breast cancer, recurrence risk. The other factors I would be thinking about personally is going to be do they still have their breast tissue? Are we not only concerned about recurrence, are we also concerned about a new cancer diagnosis as well? And what is the impact of what treatment is being considered on that risk? Number two, there's different forms of hormone replacement therapy or menopause hormone therapy, depending on somebody's age and when this is being applied. Some are estrogen alone, some incorporate progesterone as well. That depends on if someone has a uterus or not. And
Mhm.
some of those risks in terms of the specific products are going to be different as well. So we're thinking about somebody's age. Do they still have breast tissue? How long since the diagnosis? Do they have a uterus? What form of hormone therapy is being considered? What duration is being considered? What is the symptom that they're hoping will get better? Is that the optimal treatment, or are there other options that could work for that too? And that's why there's not a one size fits all answer to that question.
Right.
And there are some gaps in what is known.
Yeah. And I appreciate the studies, the Danish study, that you
Mhm.
shared, that the thinking is changing. We have better data. And so if you were told something years ago, it might be, it's a good time to go back and see what has changed, and are there options. I'm just going to ask one final question. I think this is what this person was getting at, but typically tamoxifen is prescribed for premenopausal women and AIs for postmenopausal. But what if you don't do well on an AI and you're postmenopausal? Is tamoxifen ever an option?
Yeah, it definitely is. And tamoxifen is commonly used in postmenopausal women as well.
Okay.
Tamoxifen has a small risk of uterine cancer. So if someone's postmenopausal and has a uterus, that is part of the, counseling and decision making, but it's absolutely a treatment option. And also tamoxifen is aromatase inhibitors can be detrimental to bone density. Tamoxifen is actually has a slight positive effect on bone density in postmenopausal women. So all of these different aspects are taken together. There's a very low risk of blood clot as well. So, when we're picking the right medicine for the right person, it has to do with many different factors. And if we pick one, like an aromatase inhibitor, and then the side effects are really bad, we can switch to a different one and kind of rebalance that discussion again.
Yeah. So important to have a medical oncologist that you have a good relationship with and you can be very honest. And your patients are obviously very, very lucky. And so I would encourage people, if you feel like you can't have this kind of conversation and get answers, you need to get a second opinion or find other support.